Good evening, ladies and gentlemen. We are welcome to another in the series of SSPN webinar. And this is recapping the experiences that were gained at the recently organized African Pain Camp, which held in February this year. And this is the third in the lectures to brief us and to re-educate us about the pain camp and what transpired during the pain camp. So to speak to us this evening is Dr. Stephen Ghana, the consultant general surgeon and lecturer at the Faculty of Clinical Sciences, College of Medical Sciences, Ahmadu Bello University Zaria. He is a consultant general surgeon, surgical oncology unit of the General Surgery Division, Ahmadu Bello Teaching Hospital. He is a supervising consultant at the Accident and Surgical Emergencies Units of the Ahmadu Bello University Teaching Hospital, Zaria. So Dr. Ghana has said we should just limit our introduction to this small profile. And he's already with us. So I welcome Dr. Ghana to start his presentation. Thank you.
Thank you, Mr. President, and good evening, everyone. It's a pleasure to be in our midst, and I want to thank the executives and the entire association for this opportunity to share this experience. I'm going to be talking specifically about just a little segment of the overall management of pain, as we know, and it's going to focus on the pharmacologic methods of pain management, the experiences we had from the African Pain Camp. I will discuss using this outline from the introduction to the different types of analgesics involved in pain management, and then look a little at multimodal therapy and then conclude. So by way of introduction, pharmacologic methods of pain management are a cornerstone in the control of pain, be it chronic pain or acute pain. And we all know that pain is one of the commonest presentations of patients to our hospitals. That pain may be the cause of their problems, or it may just be part of the disease process. What we experience in Africa, and Nigeria in particular, is that patients tend to present late for their disease management because of a number of factors, including finances. And pain is one of those things we notice in surgery that sends these patients to us in the hospital. Therefore, using these agents has to be tailored, tailored according to the type of pain the patient is having, its severity, and of course, it has to be tailored according to the type of patient we're dealing with. Is it an adult, a child? What comorbidities do they have? And they include a range of different types of agents, ranging from non-opioids to adjuvants. And of course, the management using these drugs should be scientifically based, and they should have the cognizance that there are side effects to these agents, to these drugs, and therefore the benefits against the effect, the side effects, negative effects have to be put in context when managing these patients. Of course, we know the ISP defines pain as an unpleasant sensory and emotional experience, which can be related to tissue damage or described in terms of tissue damage. That means there may not be physical tissue damage, but the patient is experiencing pain. Therefore, this definition emphasizes the affective component of pain management as well as the sensory. Okay, so pain is, of course, a multi-dimensional experience. Different patients have different ways they express pain. and we must understand pain from the angle of the patient. That's one of the takeaways from the African pain camp. Pain is not what you think as the caregiver, it is what the patient says it is. And therefore, we have to respect their opinions and carry them along in the management. The goals include to reduce the suffering of the patient and to improve the patient's function. Sometimes you may not have be able to take away the pain completely, but making the patient functional and improving the patient's quality of life is our general goals. So we need to, before beginning treatment, to accurately diagnose and assess that pain, and also to use various tools available to us, including the pain scores, and also consult with other professionals when managing the patients. And pharmacotherapy begins usually not with just one drug, but with a combination of drugs, which could include non-opioids and opioids, as the case may be, and also, to a large extent, using other means that are non-pharmacological. Sorry, this is just a repetition, so I'll go to the next slide. So a little bit about the pathway of pain. The pain actually occurs when hello, okay. I don't know if you can hear me. Pain begins through the process of nociception, which is actually divided into 4 steps, beginning with transduction. When a noxious stimuli like trauma occurs anywhere in the body, the first thing is for that impulse to be converted to electrical energy through a process called transduction. And this travels through specific and specialized nerves, the process of transmission, which take this pain through the spinal cord to different parts of the brain, including the thalamus and the cerebral cortex. So this pain medications, pharmacologic agents specifically target different pathways from the transmission, perception of the pain, and its modulation, so that the patient can experience some relief. Pain has also been classified in 2 ways. Can be acute, broadly speaking, 2, acute and chronic, but sometimes the line between the 2 is blurry, and so some people also talk about subacute pain. So acute pain, of course, is usually somatic, usually sharp, and as a result of some form of pain or trauma, and occurs usually within hours, minutes, hours to days. It doesn't last usually more than a month once the agent that causes the pain has been treated. While chronic pain usually lasts beyond a month, and some would say beyond 3 months, and persists in that manner sometimes, even after the causative agent has been managed. So it enters a pathologic loop where the patient suffers continuously. Some say subacute pain occurs between 1 and 3 months, but for practical management purposes, acute and chronic pain. And we have nociceptive pain, which is usually due to tissue damage and is somatic and can be visceral. And then we have neuropathic pain, which is usually due to direct nerve injury. So this is, of course, familiar to most of us, the WHO analgesic ladder. The revised, modified ladder is actually a bidirectional ladder with acute pain coming from the upper rungs of the ladder downwards, while chronic pain climbs from the lower rungs of the ladder upward. And the import of that is that in acute pain, we want to hit the pain with the highest and strongest analgesics, usually over a short period, and the patient gets relief, and we can step down in that order from strong opioids to weak opioids or non-opioids, as the case may be, in a few days. This prevents the pain from entering a pathologic loop of chronicity. While for chronic pain, the treatment starts from the lower rungs using non-opioids to weak opioids and strong opioids, along with some interventional treatment procedures. So we'll look briefly at non-opioids. They are usually effective for mild to moderate pain. They are the mainstay, and the common examples are paracetamol, acetaminophen, and then the non-steroidal anti-inflammatory agents. They are usually the first line, like I said, of management for especially mild to moderate pain. They can be combined with opioids for some synergistic effects, usually beginning with weak opioids, of course. Paracetamol is very common in Nigeria. It's one of the cheapest and the go-to drugs. The full mechanism is not understood, but it's also thought to act centrally and acts via the cyclooxygenase inhibition pathway. It has minimal anti-inflammatory action, but it also has antipyretic effects and is well tolerated. However, in patients with liver failure, the use should be guarded. It's also safe in pregnancy and in elderly patients. Non-steroidal anti-inflammatory drugs act by inhibiting cyclooxygenase, which is an enzyme that produces prostaglandin, and prostaglandin is very important in the manifestation and propagation of pain. So therefore, once this enzyme is inhibited, then pain is reduced. The examples, of course, include diclofenac and ibuprofen. They are usually used for musculoskeletal pain, mild to moderate pain, and they also have anti-inflammatory properties and antipyretic properties. They are not without side effects, and the most important side effects include the causation of gastric ulcers, and they can be renotoxic, toxic to the kidneys. So in patients with renal failure, it should be used cautiously. And they also can have cardiovascular effects in cardiac patients. New and now well-accepted class of drugs includes the specific selective cyclooxygenase 2 inhibitors. They are almost equally as potent as the non-specific COX inhibitors, but they are thought to they usually have they have less side effects compared to those examples, and the common example is Celebrex, which is celecoxib. They can be given orally. Most of them are oral drugs. Therefore, sometimes can be difficult to use in patients who cannot take orally. So a wide range of presenting complaints can suit the use of Celebrex and other COX-2 inhibitors, including rheumatoid arthritis and in the post-op patients. They should, however, be used with caution in cardiac patients. So adjuvant analgesics include other classes of drugs that are used for other reasons primarily, but can also be employed in the treatment of pain. And they include antidepressants, anticonvulsants, corticosteroids, and muscle relaxants. Usually, these are very handy when managing chronic pain and pain of nerve origin, neuropathic pain. So we'll start with the antidepressants. They are useful for neuropathic pain and in difficult conditions like fibromyalgia. They include the tricyclic antidepressants, with amitriptyline being the classic example here. The way they work is by inhibiting serotonin and norepinephrine reuptake. So we can have selective inhibitors, which include duloxetine. They are better tolerated and have fewer side effects. However, they also have other psychotic benefits, including improvement of the patient's mood and also help the patient to sleep better. Anticonvulsants reduce neuronal excitability, and this is explored in their use for pain management. And the examples include gabapentin and pregabalin. And at the conference at the African Pain Camp, we were taught that these two can be used interchangeably. While one is preferred in the United Kingdom, the other is preferred in the United States, and they have similar effects. None is superior to the other, just like saying Coca-Cola and Pepsi. Okay. Usually, they are begun at a lower dose and titrated to effect, and also they are not stopped abruptly to prevent side effects. The side effects profile include dizziness, sedation, and weight gain. Muscle relaxants also have a role to play in management of pain because they reduce muscle spasm in patients who have somatic pain, and the reduction of this spasm can improve pain. The common agents include methocarbamol. They act centrally on the brainstem and also on the spinal cord. Side effects include sedation, dependence with prolonged use. So in chronic use, one has to watch out for dependence. Corticosteroids are also useful in pain management because they reduce inflammation. They have very strong anti-inflammatory properties, and in cancer pain, they also play a good role, as well as patients who are suffering from traumatic spinal cord compression and also musculoskeletal pain and joint aches like arthritis. Usually preferred as short-term agents, and their side effects include hyperglycemia, osteoporosis, and mood changes. We come to opioids, which I decided to just reserve for the end of the lot because they form one of the mainstays of management of moderate to severe pain, especially acute pain. Chronic pain with a lot of caveats. It is not routinely used, as we learned from the African Pain Camp. It's not used for routine chronic pain management, but for select patients. And these select groups include cancer patients who are being palliated and for end-of-life care. Other uses, other causes of chronic pain. Usually we don't encourage the use of opioids, of course, because of the side effects which we'll talk about briefly after now. They act by binding to opioid receptors, including mu, kappa, delta, and sigma. And the examples, of course, include morphine, which is a strong opioid, hydromorphone also, and fentanyl, and then oxycodone. Of course, the fear and the risk of misuse or dependence usually makes caregivers and even some patients a bit worried about the use of opioids. And sometimes, especially in acute pain, this is unwarranted because studies have shown that when used for short periods in the control of acute pain, the fear of addiction is actually baseless scientifically. And also response to pain. There are strong analgesics in that regard. They also reduce transmitter release in the spinal cord. Because the common side effects include constipation, nausea, and vomiting when they are used. They can be used through different routes of administration, including oral. Tolerance, however, is actually is a physiologic process, which usually is also called physical dependence, and just occurs with decreasing. It's a reflection of the decreasing response of opioids over time, and sometimes it means that the dose has to be increased for you to get the same effects as you were getting with slower doses before. So there are usually some medications that help to limit these side effects. For example, in the surgical patients who you want to have good functional bowel return, laxatives can be combined to prevent constipation in these patients. One of the takeaways from the pain camp is that no single modality is effective in the management of pain, whether in the acute or in the chronic setting. And usually a multimodal approach, and beyond just multimodal, should be multidisciplinary, and beyond multidisciplinary, it should also be interdisciplinary. So the difference between the two, of course, is multidisciplinary means that different professionals come to are involved in the management of a patient. But when we're looking at the interdisciplinary management of pain, it means that these disciplines come in a unified form, like a team, to manage the patient with no single professional superior to the other. And that's what we promote in the pain clinic and in pain teams, so that everyone, whether it's the doctor or the nurse, or it's a physiotherapist or the psychologic therapists, whoever it is, has a platform to express themselves and contribute positively to the management of these patients. So drugs should be combined with other forms of treatment to actualize adequate treatment of pain. So multimodal, of course, means we can combine, in the pharmacologic sense, we can combine different classes of drugs. That way we reduce the side effects of each of them, and we improve the patient outcomes with them. And of course, we can combine drug therapy using oral or parenteral routes with some form of regional anesthesia. All this is aimed at better outcomes for the patients while reducing the need for high doses of drugs, especially opioids. So one of the highlights of the African Pain Camp was when the current president, Andrew Rice, gave a lecture about the evidence base for the use of cannabinoids in the management of pain. Before now, of course, there is a lot of rave about these drugs helping with pain management. However, human trials show limited and inconsistent evidence for the effect of cannabinoids when used in treating pain. Most of these studies are flawed because of their small sample sizes. It increases bias. Most of them are done over short periods, and the methodology is usually questionable. So the overall takeaway from most of them is that the evidence is of low quality.
Okay.
Of course, there are safety concerns, which include safety of that the safety profile of these drugs are very limited because they are given at different doses. You cannot dose them. You cannot know what concentration the patient is taking to produce what effects. And most reviews show that most of these are inconsistent and of low quality. So, of course, more needs to be done in the area of studying cannabinoids and their role in the treatment of pain. But as it is presently, they have very limited role because there's no evidence. So the ISP concluded that current clinical evidence is insufficient to recommend cannabinoids for pain treatment. So rigorous research is necessary and needed before endorsing this class of drugs. In February this year, Jonavix, suzetrigine, was approved by the FDA of the United States for the management of pain. It's a new drug that is causing causing some interest because it's a non-opioid analgesic. Therefore, in the face of the opioid crisis, it's seen as one of the answers to divert from the use of opioids to something else which doesn't have the same side effects. It's used for moderate to severe acute pain. However, chronic pain has not been studied enough, and for now, there is no active role for suzetrigine in the treatment of chronic pain. The side effect profile is not like that of the opioids because it doesn't cause addiction. But the effects include side effects include itching, muscle spasms, and rash. So, by way of conclusion, pain management is individualized and it is multifaceted. It is based on the patient, and also it includes different teams of specialists. We can employ the WHO ladder in both acute and chronic pain. And when using pharmacologic agents, we have to monitor their efficacy and their side effect profiles, balance the benefits against the risks, and then combine pharmacologic with other treatment strategies. Again, the takeaway from the African Pain Camp was to de-emphasize using the word non-pharmacologic so that it removes that inferior role that it may seem to have. So instead of calling them non-pharmacologic strategies, it's better to call them by their specific names: physical therapy, psychologic therapy, and whatever other. As healthcare givers, we must continue to increase our knowledge of pain control and also be committed to provide optimal analgesia when dealing with patients. We should not assume their pain is smaller than what they say it is, and we should treat it with pharmacologic as well as other modalities of treatment. Thank you all for listening. When in Zaria, please stop by Faculty of Clinical Sciences and Surgery in Specific. I'll be glad to host you. Thank you.
Thank you for this insightful presentation, Dr. Ghana. We appreciate this. Do we have questions on the platform? I don't know if anybody put in question in the chat box. Absolutely, I cannot see them again because I had challenges with my Zoom and my network. But we can retype our questions. So do we have questions for Dr. Ghana? I think Professor Odole may want to say one or two things.
Thank you, sir. Good evening, everyone. I've already typed something in the chat box, thanking Dr. Ghana for the succinct presentation. And just to emphasize the importance of interdisciplinary mode of pain management. Thank you.
Okay, so people are appreciating Dr. Ghana for the wonderful presentation, reminding us about the pharmacological method of treatment of pain, the good and the bad, the good effect and the side effects. So please, if you have question, you can raise up your hand or you unmute yourself and talk. Otherwise, we do not have any question in the chat box yet, except
I compared the two.
177, can you mute yourself? You are not asking a question. So Dr. Ghana, what do you frequently use in the treatment of pain in your hospital center?
Okay, thank you for that question, sir. For the treatment of pain in my center, of course, I'm tempted to start from my own little area in surgery. However, it's good to know that the treatment of pain, like we have discussed, begins with understanding the patient, understanding the type of pain the patient has, so that goals of therapy can be drawn up, be it acute or chronic pain. And drawing those goals are very advantageous because you know the right teams to bring in, the right specialists to bring in, and you also help the patients to be on board with the treatment goals. I'm talking about this because the management of chronic pain, which usually is one of the main things in pain clinics, requires the patient to be carried along. And those goals should be practical goals and achievable goals. In other words, it should be SMART goals. So back to the question, what do we use commonly? We use pharmacologic agents, including opioids, especially for acute severe pain in the setting of trauma and surgery. Then we scale down to weak opioids and non-opioids. Common opioids we use in my center include fentanyl, pentazocine, and morphine. Morphine in my center especially is key because we have both the parenteral and the orally formulated forms of morphine. So in cancer patients, we give them the oral morphine, and it's very helpful in management of cancer pain. In the setting of chronic pain, of course, we combine with other modalities of treatment, including physiotherapy, which is key in my center in the treatment of chronic pain. We also use other ancillary adjuvant drugs. And sometimes we may need to use to also invite the psychologists as part of the treatment. The only takeaway I mean, the only thing I would say that is yet to fully come on board in my center is the running of an active pain clinic. Is something we hope in the near future to organize, because we have the basic team members that will constitute the team. But what I think what is lacking is the coordination. About the use of nefopam. Okay, sorry, come again. Hello, sir.
Oh, there are questions in the box. I don't know whether you can see them. Oh, we lost him again.
Dr. Aneti, that's what I was trying to answer. Asked the question about the use of nefopam as an analgesic. So I don't know where you stopped hearing me, but I'll just take it again from the top. I said nefopam has actually been studied in my for his dissertation thesis. And what he found was that nefopam has a good role in the management of surgical pain. It's quite effective in the management of acute severe pain. My goodness, what is this?
We lost him again.
Trying to look at the questions so that you can just respond to the questions one after the other.
Yeah. I don't know why it keeps going off, but I'm using my phone now, so I hope it should.
Can I read the questions out for you?
Okay, so I was answering the question on the role of nefopam.
Yes, nefopam.
Yes, so I said someone did a study in my center and found nefopam should be effective in the control of acute pain, especially in the surgical context. So we compared the use of nefopam with placebo and an NSAID, and found that nefopam is effective in controlling acute pain. So that's what I know about nefopam from an experience from my center. Thank you.
There's another question that how do we navigate a situation where a patient is in pain and the patient is rejecting medication to relieve the pain on account of spiritual beliefs? I'll read the question one after the other as you respond.
Okay. Yes. So incidentally, that is not also is not an infrequent occurrence, even though, yes, it's not as we don't encounter it so much as compared to blood transfusion because we know, of course, there are religious beliefs who are against the use of blood. However, one can think of very few ethnicities or religions that actually forbid pain. Usually, forbid the use of analgesics. The setting that some of these come are especially in a woman who is delivering. Some people believe that when in labor, they should bear the pain of labor without analgesics. And so sometimes it's to understand, the most important thing is to understand the context of the patient and to educate the patient on the need for treatment, especially when that pain is going to interfere with the patient's outcomes, and also to utilize other modalities that the patient is likely to accept. So if a patient does not want pharmacologic agents or does not want injections or does not want tablets, then we can lean and leverage other forms of pain treatment that the patient is likely to accept. And this include physical therapy, psychological therapy, and even some diversional therapy sometimes. These patients tend to accept spiritual counseling, and this sometimes play a very key role in helping the patient through the process. So it's not always about having our way as physicians, but also respecting the patient's wishes in the context of promptly and adequately managing the patient. Thank you.
Thank you. The next question is, post-op, are there maximum doses of drugs that can be used in patients with severe pains that don't respond to normally prescribed doses?
Yeah, so there are various agents that we can combine, and when you're talking of maximum or minimum dose, I would like to use the opioids as an example. Many of us caregivers tend to err too much on the side of not giving enough analgesia, especially opioids, in the setting of acute pain, such that many people underdose the patients, or instead of using strong opioids for severe pain, tend to use weak opioids. And all these end up managing the pain poorly. Opioids in the setting of acute pain are found to be safe, and they can be given once the context of the patient and the attendant comorbidities are understood. Then these drugs can be combined from different classes such that they are synergistic. And we can also combine regional anesthesia with either intravenous or oral medications, as well as combining them with other forms of therapy. By the time we do this, the fear of overdosing or underdosing sometimes can be mitigated. Thank you.
Thank you. The next question from Adamu Usman Gamawa. At what level or circumstance?
Hello, Prof. Hello, Prof.
Hello?
I have a little addition to the first and second questions.
Yes, I was thinking that I will come there when he has answered so that we can give you an opportunity to search all of the questions. Then I will now read your comment because I already saw your comments, Dr. Latejo.
Okay, all right.
Okay, I just want him to respond to all of the questions. At what level or circumstance do you combine pharmacological treatments and alternative treatments such as physiotherapy?
Yeah, so that's also a good question. As much as possible, at every level, the treatment of pain should not be seen as a one modality treatment, be it acute pain, be it somatic pain, be it chronic pain, nociceptive or neuropathic. There is more to gain from combining different modalities as well as combining the multiple prompt and satisfactory in different specialties. Thank you.
Dr. Ghana, we cannot hear you.
Yes, please. I can hear you. Can you hear me?
Yes, we can hear you now.
Okay. So yeah, I think I answered that. Did you hear did I?
Yes, you answered that. Yes. I'm talking about pharmacological and physical and psychological.
Because the question was on at what theological order. So I said that from the outset, it is better to combine modalities and to combine disciplines. So it should be interdisciplinary and multimodal for both acute and chronic pain. Thank you.
Thank you. The next question from Stella Kokowicha. How can oral morphine be made available outside teaching hospitals when needed? Dr. Ghana, are you there?
Hello?
Hello, did you hear the question?
No, I didn't. Can you come again? I'm
Okay.
hearing you now.
How can oral morphine be made available outside teaching hospitals when needed?
Okay, that's another very important and good question. Oral morphine should be available not only in tertiary hospitals, but it should be available where it is needed. And we know that most of our indigent patients, one of their first points of call are the primary and secondary care facilities. And as pain champions, this is what we need to work on to make sure that these medications are available everywhere, and not just in the tertiary centers. I'm not currently aware of any programs that promote the use of strong opioids in primary healthcare settings. So I think this is a call to duty for the association. We should champion the availability and the use of every medication in the safe context for patients. As a matter of fact, we know that most cancer patients and most patients requiring palliative care are not in the tertiary hospitals. They may visit, they may be managed there, but most of the time they are either in their homes or in some care facilities. And so this is one way to make these medications available to them after counseling and making sure they understand the side effects and the adverse effect profile of these medications. And with regular follow-up, they can be discharged home with these medications. Thank you.
Thank you. We're actually running out of time. If Dr. Ghana can just respond to this question in 30 seconds. Is it true that combination of PCM and diclofenac gives same outcome like analgin? Like analgin no longer in use? Can you just briefly respond to that so I can actually hand over to the president, even though Dr. Olaseju would like to say, even if he can say it in 30 seconds too.
Hello,
Dr. Ghana?
Yes, you are back now. Thank you.
Okay, yes. Is it true that combination of PCM and diclofenac gives the same outcome like analgin? And analgin that is no longer in use? Briefly respond to that.
The combination of, there are many drugs and formulations that are in the market today, different forms of NSAIDs, and even weak opioids are combined with paracetamol. Yeah, so, and that is mainly to increase the effect profile while decreasing the side effects of using either NSAIDs alone or using paracetamol alone. Note that There are settings in which paracetamol is also avoided, or it's used with caution, especially in patients with renal failure. So many different combinations can be used safely and as effective as drugs that are out of the market, including analgin. Thank you.
Thank you. We are at the nick of time. I don't know if our president would briefly allow Dr. Lateju to please make his own input in the next 30 seconds.
Okay, thank you, Professor Odele.
Well,
One of the lessons from the health campaign camp, according to Dr. Ghana, is the multidisciplinary approach to pain management. So concerning the question on spiritual belief, that is why we have psychiatrists, clinical psychologists, clinical sociologists, religious leaders. They are part of pain management, and we must make use of them. So that is why the Pain Society is the largest multidisciplinary association in the entire health institution. So another thing I want to quickly say is that of the maximum dose of analgesic. Also, we have pharmacists as part of pain managers. So if you are in doubt of the dose, you can check your literature, or you can consult one can consult a pharmacist. And concerning the allergen is totally out of market. We should not be talking about that now. So even before the total abolition of allergen is primarily used by the veterinary doctors. Allergen are being used for animals, not human being again. Thank you.
Thank you, Dr. Lateju. Dr. Ghana, we want to say a very big thank you to you. Thank you for addressing all the comments and all the questions. Thank you. At this point, I want to hand over to the president of the Society for the Study of Pain in Nigeria. Over to you, sir.
Thank you so very much, Dr. Ghana. Despite all the challenges and the odds, we were able to get to the. I want to thank Professor Dole for standing in, and we have other people on the. Dr. Lateju, thank you for organizing the cohorts of those who went to the African Pain Camp for presentation behind the line to make sure that everything work very well. It's a multidisciplinary society where everybody is involved. If you are a healthcare provider, if you are in research, management of pain, we are all welcome to become a member of the society. And you pay a member and you benefit from some of these and additional benefits. Next month, we have our meeting coming up in Uyo, and it promises to be a very good offering. So we are not going to have a webinar for next month. We encourage every one of you to submit abstracts, make your presentation during the conference, and plan to attend the conference. We want to thank every one of you. Please, as much as possible, become a member of the Society for the Study of Pain in Nigeria. So I want to appreciate every one of us that have found time to join this webinar this evening, and to thank my team members, the National Executive Society, the Treasurer is here, Dr. Montoye, and then I could also see Dr. Dada is unavoidably absent, the Secretary. But we want to thank every one of you so very much for coming up to join this webinar this evening. So hopefully, please warm up for the last in the series of this feedback from the African Pain Camp, which was held in February this year. We are going to have a presentation on how you can use nutrition to manage pain, and I'm sure. And she, Dr. Mrs. Ododo. Thank you for attending.
Professor Ajawu, Professor Akpanle, we thank you for